Madam, we are live now.
Yeah.
Good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcome you all in today's session of role of myoinositol in male infertility. And our guest speaker is Dr. Lilavati Guru, madam. Although everybody knows madam, but it's my formal responsibility again to introduce madam. Madam is the senior consultant in obstetrics and gynecology at Cuttack, Odisha. And madam has more than 20 years of experience in the field of gynecology and special expertise in the field of infertility. And madam is a part of many international and national conference, both as a faculty and as a delegate also. And her outstanding contribution to social service as well and unparalleled dedication to service has always been the hallmark of her personality, for which she was awarded the prestigious Shiva Ratna Award. So, with this short introduction, I request Madam to take over the session, and meanwhile, I request all the participants for your active participation, and please post your queries on the dashboard of the Shield Connect page. So, once the talk will be over, we shall have a short discussion on this topic with Madam. So, thank you very much, Madam, for your valuable time in our platform Shield Connect to discuss this important topic. And over to you, Madam, for further proceedings. Thank you very much.
Good evening, everybody. And today, my topic is role of myo-inositol in male infertility. As we all know, myo-inositol is a therapeutic option in female infertility where there is insulin resistance or in PCOS. But this role of myo-inositol in male infertility, yes, it is somehow a very newer thing. And what is infertility? As we know, all know, infertility is the inability of a sexually active, and the couple are not using contraception to achieve spontaneous and they fail to achieve spontaneous pregnancy in 1 year. So, as we are now dealing with male infertility, I am telling you why male infertility may be impaired spermatogenesis, which may result from hypothalamic pituitary or testicular disorder. Male infertility is almost, it is 30 to 40% of the cases of infertility, male factor contributes to infertility in 30 to 40% of cases. Semen analysis is the cornerstone for diagnosis of male infertility. Though in some cases there is normal sperm parameter, but sperm do not function in a manner necessary for fertility and can still be cause infertility, can cause infertility. Inositol acts as a second messenger which regulates several hormones such as follicle stimulating hormone, thyroid stimulating hormone, and insulin. The male reproductive tract tract is also male reproductive tract is also has a higher concentration of myo-inositol, and this myo-inositol is a sugar-like molecule considered as a member of the vitamin B complex, and it is one of the most important cell membrane elements involved in the synthesis of lipids and cell growth, and is also considered as one of the countless neurotransmitter precursor such as serotonin. And recently, various studies have shown that myo-inositol is one of the precursor for synthesis of phosphatidyl phosphatidyl inositol polyphosphatase. It is an enzyme. So, what are the types of male infertility? It is asthenospermia. Asthenospermia where the motility is less, and teratozoospermia where much of the sperms are abnormal in form, and oligospermia where the count is less, and azoospermia where we don't see any sperm. So male infertility, as we all know and we have discussed, male infertility accounts for 40 to 50% of infertility, and it affects 7% of all men. The normozoospermia was observed in 35.8%, oligozoospermia in 34.1%, asthenoteratozoospermia in 19.35%, and azoospermia in 10.7%. One of the factors that may cause male infertility is it may be an etiological factor, that is the overproduction of reactive oxygen species. Reactive oxygen species are represented by a broad spectrum of molecules, including oxygen-free radicals such as superoxide anion, hydroxyl radical, and hyperoxyl radical. Non-radical species such as hypochlorous acid and hydrogen peroxide, and reactive nitrogen species and free nitrogen radicals such as nitroxyl ion, nitrous oxide, and peroxynitride, etc. One of the several conditions increase the oxidative stress in seminal fluid. So what are these conditions? These include pathological conditions involving the reproductive tract like varicocele and prostatitis. And if there is some lifestyle changes like smoking, alcohol abuse, drug addiction, etc., etc. And environmental pollutions like radiation, smoke, industrial gases, also produces reactive oxygen species, and nutritional errors like unbalanced hyperlipidemia diet is also responsible for it. The most prolific source of reactive oxygen species in sperm suspension is a nicotinamide adenine dinucleotide phosphate (NADPH) oxidase located in leukocytes or in spermatozoa. Those are abnormal spermatozoa or premature spermatozoa that produces superoxide that is further converted to peroxide by the action of superoxide dismutase. So this hydrogen peroxide has been recognized as the most toxic oxidizing species for human spermatozoa. And these human spermatozoa, which are very sensitive to lipid peroxidation, owing to the high content of this spermatozoa plasma membrane has a high content of polyunsaturated fatty acids in their plasma membrane. Though this is not the sole mechanism through which the sperm function might be impaired by ROS. As we all know, mitochondria are the storehouse of energy, and this mitochondria is required by the spermatozoa for the performance of their function like capacitation, acrosomal reaction, and fertilization. This ROS may induce change in this mitochondrial membrane and may thus compromise sperm function. It has been shown that mitochondrial membrane potential and ROS levels are inversely correlated. Why this relationship? There are two causes. One is ROS causing damage to the mitochondrial membrane, and the damaged mitochondrial membrane causing increased ROS production. The sperm chromatin condensation is a process that is very susceptible to increased oxidative stress. These spermatozoa have a very low DNA repair mechanism. So once this DNA is damaged, the spermatozoa is not able to repair it. The sperm membrane contains high levels of polyunsaturated fatty acids. So these are more prone for this reactive oxygen species, and spermatozoa themselves produce ROS, especially during passage through epididymis. Spermatozoa have low levels of cytoplasmic oxidative these low levels of cytoplasmic antioxidant enzymes, because most of the antioxidant enzymes are lost in spermiogenesis, and these spermatozoa spend long periods as isolated cell in both male and female genital tracts. So it is in May 2019, volume 7 in andrology, they have seen that low myo-inositol levels within the epididymis and in seminal fluids are associated with reduced fertility. Myo-inositol concentration is significantly higher in the seminiferous tubules than in the serum of a person. In male reproductive organ, myo-inositol is mainly produced by Sertoli cell in response to follicles, in response to FSH, and is involved in process that include the regulation of motility, capacitation, and acrosome reaction of sperm cell. Myoinositol play a role in the osmoregulation of the seminal fluid, and this osmoregulation is very important because both hypo and hyperosmotic media have been found to significantly decrease sperm progressive motility and velocities. An increased amount of a particular enzyme, that is inositol 1 monophosphatase IMPA1, which is involved in the dephosphorylation of that enzyme which I have told you, phosphatidyl inositols have been detected in asthenozoospermic patients. Therefore, it is possible that increased expression of IMPA1 in asthenozoospermic patients would alter this PTD-INS signaling pathway and therefore induce a reduction in sperm motility. This sustains the role of signal transduction pathway induced by PTD and PTD-INS in the regulation and maintenance of male germ cell motility. Myoinositol acts directly on mitochondria, increasing the membrane potential. It increases the membrane potential of the mitochondria. And this mitochondrial membrane potential is an apoptic marker clearly related to functional parameters of the sperm cell, including motility, the capacity of fertilization, and embryo quality, and is therefore used as an index of fertility. High values of these mitochondria membrane potential indicate the integrity of this structure with optimal levels of activity and are associated with high cell viability. So, asthenozoospermia and myoinositol. If there is absolute asthenozoospermia, then you have to do HC. If there is relative asthenozoospermia, like progressive motility is less than 32% and total motility is less than 40%. It is from the WHO criteria 2010. And what is the exclusion criteria? You will exclude the patients in which cases? The male accessory gland inflammation, leukocytospermia, papillomavirus infection, semen hyperviscosity, and when the testicular volume is less than 12 ml. So evaluation of the mitochondrial membrane potential is to be done, and when there is low mitochondrial membrane potential, you give myo-inositol. Freshly ejaculated spermatozoa are incapable or poorly capable of fertilizing an oocyte. So the fertilization aptness of spermatozoa depends on the appropriate and time-dependent acquisition of three important biological processes. It will not firstly, it will not. It cannot. The ejaculated sperm cannot fertilize an oocyte. So, what are the three biological processes? One is capacitation and hypermotility. Second is chemotaxis. Third is acrosomal reaction. And this all causes calcium ion oxidation. And this myo-inositol helps in this calcium ion oxidation. What is capacitation? The spermatozoa of patients with oligoasthenospermia are covered by amorphous, you can see here, is covered by amorphous fibrous material that increases the seminal fluid viscosity and reduces the sperm motility. These amorphous fibrous material are responsible for decreased motility due to increased viscosity of the seminal fluid. Furthermore, the mitochondria in the intermediate tract of spermatozoa for patients with oligosteroteratospermia have damaged cristae. However, after supplementation of ionositol, this amorphous fibrous material disappeared and cristae damage is decreased. In epididymal, you can see in this picture, the epididymal spermatozoa, the plasma membrane of epididymal spermatozoa contains a complement of surface molecules, protein and carbohydrate. And when it is mixed with some seminal plasma, when it is ejaculated, the surface molecules in the epididymal sperm become coated with seminal plasma protein. This orange halos that mask the portion of the membrane of the membrane molecules. And in the female tract, when there is capacitation occurs, when sperm are exposed to the female tract environment, these seminal plasma coatings along with some of the surface molecules are removed, thus exposing the portion of the molecules that can bind to the zona pellucida of the oocyte. Chemotaxis plays an important role of fertilization. Chemotaxis refers to the directed movement of the sperm to the oocyte. Oocyte releases chemoattractants. From the zona pellucida of the oocyte, small amount of progesterone is released, and this progesterone acts as a chemoattractant to the sperm. But these when if you only give progesterone, only presence of progesterone will not help in the motility of the sperm. It is also the calcium, and that calcium will also help will act as a trajectory of sperm movement. And these calcium bursts trigger chemotactic turn associated with dynamic changes in the flagellar bits. And this calcium burst occurs with the help of myo-inositols. So myo-inositol helps in the calcium burst. Spermatozoa acquires motility during the epididymal transit, becoming able to migrate from the vagina to the fallopian tubes to penetrate the cumulus oophorus and to carry out all the process involved in fertilization. At first, after penetrating the cumulus oophorus of the ovum, the spermatozoon binds to the zona pellucida with its plasma membrane intact. Then it undergoes the acrosome reaction. It will not, acrosome reaction will not happen after, during penetration. It will only happen after penetrating the cumulus oophorus. This results in the release of hydrolytic enzymes that digest the zona pellucida, allowing the spermatozoon to penetrate into the oocyte and to fertilize it. All these events are allowed by inositols and particularly by increasing the intracellular calcium release through inositol gated channels because of a protein kinase activation pathway. So you can see here there is acrosomal reaction. The sperm head is coming and it is attached to the zona pellucida. Then there is acrosome reaction, and this sperm will fertilize the egg. Calcium signaling events that mediate the acrosome reaction. This is the all these pathways are helpful for this acrosome reaction. There is increased levels in the sperm calcium level. All these reaction causes increased calcium levels in sperm cytoplasm. So these are some papers. It is a published paper in 2011. The effects of myo-inositol on sperm mitochondrial function in vitro. So they have seen that the concentration of myo-inositol in the seminiferous tubules fluid is higher in the level higher than the level found in the seminal plasma. Myo-inositol in mitochondrial membrane potential. Myo-inositol also directly increases the mitochondrial membrane potential, that is an apoptotic marker of in the sperm cell. Myo-inositol seems to have a beneficial effect on motility, fertilization capacity, and embryo quality, as demonstrated by in vitro studies in the sperm of normal and oligoasthenoteratoformia patients undergoing IVF. Myo-inositol also decreases the DNA fragmentation, and this is also a study it is in an andrology book. They have suggested that the impact of in vitro semen supplementation with myo-inositol upon DNA fragmentation was addressed in a cross-sectional study done in men and presented at the 2015 ESRI meeting by Parmigiani and collaborators. Although a preliminary report, a significant overall decrease in DNA fragmentation was determined in myo-inositol treated sperm, although not expanded to a larger good. So this myo-inositol also improves sperm parameters and serum reproductive hormones in patients with idiopathic infertility. And this is a prospective double-blind randomized placebo-controlled study in this is in 2015. And they have done a double-blind randomized placebo-controlled trial in Italy, where they have taken 194 patients, and they have subjected 98 patients were given myo-inositol, and 96 patients were given placebo. And the dose of the myo-inositol was 4 grams per day, and the duration of the treatment was 3 months. And they have seen that this, you can see those who have given myo-inositol, their before treatment and after treatment, and those who are treated with placebo, before treatment and after treatment. You will see that BMI and BMI is not affected much. Testosterone level is also not much, not affected much. Ejaculated volume is not also affected much, and but only this you can see this LH level has come down from 12 to 8 in myo-inositol group, and the FSH level has also come down from 16 to 10, and this and most important is inhibin. You see the inhibin level has gone up from 86 to 105, and in placebo group there is no change. And this is also a clinical study where they have seen the effect of myo-inositol and antioxidants on sperm quality in men with metabolic syndrome, those who are suffering from diabetes, hypertension, etc., etc. So they have seen that concentration and motility and normal morphology has increased significantly because the p value are less than 0.001. In summarizing, myo-inositol concentration is significantly higher in the seminiferous tubule than in the serum. Myo-inositol is mainly produced by Sertoli cell in response to follicle stimulating hormone and is involved in the process that include the regulation of motility, capacitation, and acrosome reaction of sperm cell. It has been suggested that myo-inositol may play a role in the osmoregulation of seminal fluid. myo-inositol can improve the sperm mitochondrial function, thereby improving sperm motility in patients with altered sperm parameters. Patients with idiopathic infertility could take advantage by myo supplementation. Thanking you all for your present hearing, and I must thank the Steel Health people for allowing me, for giving me an opportunity to talk this topic.
Thank you very much, madam, for this nice presentation. You have covered almost all the things. Just give me 1 minute time, ma'am, to check the dashboard if any question is there. Yes, ma'am. Ma'am, one thing, ma'am, how long do you recommend this myoinositol in case of this male infertile patient? Ma'am, am I audible?
Hello.
Am I audible, madam?
Hello.
Madam, am I audible?
Yeah, now you are audible.
Okay, ma'am. So, ma'am, thank you very much, first of all, for this nice session. And just I have one question, ma'am, that how long this myoinositol can be recommended for this male infertility, or in your practical experience or practical practice, how long you recommend this myoinositol?
Because when you told me na this to present this topic, so I just want from I previously I am not I usually I am not using myoinositol for male infertility. I am only using it for female infertility. I think I will use it from today only in male infertility.
Thank you, madam. And okay,
And
madam.
I think myo-inositol is not, you can give it for a longer period, because in PCOS cases, we are giving it for 1 year and like that. So it is not at all a problem to give more than 3 months.
Thank you.
We can give it for 6 months also.
Yes, madam. Another thing, ma'am, means apart in this means as your practical practice, you have not used till now, but as you means, I hope that you are convinced with this effect of this myoinositol on this male infertility. What is your opinion on that, ma'am?
I think it will, because you see, male infertility is very difficult to treat. There is not any particular, there is no particular drug which can improve the motility or improve the quality of the sperm, or improve the count of the sperm also. There is no proper drug has been, it is not available. So I think let us try myo-inositol. What is the harm? And it is not a, it is available in our body. It is a natural product. So I think we must use it. We must recommend it. We must we must treat the male infertile patients with myo-inositol.
Thank you very much, madam. Just to share one information that, ma'am, it serves as a precursor for the synthesis of inositol triphosphate, basically. So depletion of this can disturb the dynamics of the intercellular calcium oscillation, what we used to say. So basically on that mechanism only it helps in this male infertility. So thank you very much, ma'am, for your suggestion and your opinion on that effect of this myo-inositol on this male infertility. And thank you very much, madam. I could not find any other question right now. So if you allow us, then we can conclude this session.
Okay, thank you.
Thank you very much once again, ma'am, for your valuable time on this platform Shield Connect. And in future also, I will look forward for some valuable session with you, madam.
Okay, thank you.
Thank you very much, madam. Have a good day, ma'am.
Ma'am, thank you so much for your time here, even after your busy, attending of that surgery, and you have given a wonderful time for us. Really, we are grateful for that, and we look forward for more and more webinars like this, ma'am.